So I'll start recording, and I will say that again. So this exam is going to be the exact same format as the other 3 exams. Your 2 short answer questions, your 40 multiple choice questions, you'll have 50 minutes to complete it. It's going to look exactly the same. It's going to be on your Moodle page exactly the same as all the other ones were. So once I get the questions uploaded, I will basically just set it to visible so you'll be able to see it in that list. I will keep tests 1, 2, and 3 there because for some reason people were having trouble accessing the grades, which is weird because last semester I had them hidden and you could still see the grades in the grade book, but apparently they're not coming up this time if I hide them from the homepage. So you'll see exam 1, 2, 3, and then right after it will be your final exam. So you'll click on that and you'll complete it just like you would any of the other exams so far this semester. Let's see what's in the chat. Yeah, and I mentioned this a little while ago as an answer to someone's question, but the exam is 7 p.m. tomorrow night. So 7 p.m. on April 22nd. So you won't, it hopefully won't take you any longer. Basically, I'll set it to open at 7 and close at 8 to give people a little bit of leeway. So if you started at say 7:05, you'd still have your full 50 minutes because it won't close until 8 p.m. So I will basically set up everything like I have for the other exams. So usually with these reviews, and I know I apologize, the last review was a little odd because I was in a car in Winnipeg and that was a little strange. But I think we did go through probably almost all of the review guide. I think we didn't get through all the therapy stuff, but I'm pretty sure we got through all of the chapter 15 stuff. But we can basically go through whatever you want today. If there's one particular topic you're struggling with, if you have any questions on things, now's the time to ask them. So I'll open the floor. I'll give you a few minutes now. If anyone has any specific questions about any of the content or about the exam, you can either type them in the box or you can unmute yourself and let me know, and I will do my best to answer them.
I just had a quick thing I would like to clarify. I think when we were going over the review, did you say we just had to focus on like cluster B personality disorders?
Yeah, so if I do ask a short answer question, it would be on the cluster B ones, or it would give you a choice to just like name any personality disorders and talk about them a little bit. But the cluster B are the ones that used to be focused on in the old textbook. And they will be, you know, there could be multiple choice about any of them, but if I asked you as a short answer, you would have a choice of which ones you want to describe. I would either ask you to do cluster B or I would ask you to do any of them that you want to talk about. So if you do focus on the B ones and know like the basics of the other ones, just like, you know, a 1-line description, that should be fine.
Okay, thank you.
Yeah, I won't ask you anything intense about them. I'm particularly, I shouldn't say fond of personality disorders. That sounds really odd, but they're one of my major clinical interests. They're something that I spent a lot of time researching. So I love talking about them. You all probably don't love talking about them as much as I do, but the ones in cluster B are the ones that I kind of focus on more so with my research and things like that. So they were not only the only ones in the old textbook, they're also the ones that I personally find the most interesting.
Okay, I have a question. Like, do you want question 3 in chapter 16 that you asked us to list and describe some potential barriers to treatment? Yeah, I'm trying to like figure out the answer. Is it that because it's ambiguous, that's why is one of the barriers, right?
Mostly the barriers to treatment would be the things like logistics. So like it's really expensive a lot of the times. It's really hard to find a therapist a lot of the times. It can be hard to find a therapist client match. So for example, some people of certain races or ethnicities want a therapist that matches that race or ethnicity. Some people who are members of the LGBTQ community want people who are members of that community. I should say LGBTQ plus. That's the way I kind of accommodate all of it because I can't remember all the letters. But yeah, so the barriers would be more so stuff like that. Like it's sometimes very hard to obtain the treatment that you would need. So I'll pop up the notes quickly because there is, it definitely isn't, I can see where you're coming from because it definitely isn't listed as like just a giant list of them. They're kind of talked about a little bit
17
here. Yeah, so there's some right here, right? So some of them, you know, people often delay seeking treatment. Oh yes, and so yeah, this is the one that you're talking about. The disorders themselves
Yes.
are ambiguous. So basically what that's saying is like sometimes it's really hard to separate what is disordered from what is an everyday issue, right? Because you know, something like grief, for example, everyone grieves. You know, when you lose a loved one, you go through a period of grief, and that's normal. But when the grief becomes so kind of intense and so prolonged that it's affecting your daily functioning months and months later, that might be considered disordered, right? So that's what it means when it's talking about like they're ambiguous. Is like somebody who's grieving, they might be thinking, well, am I dealing with something that needs to be treated, or am I just dealing with normal grief? Right? So sometimes it's hard for people themselves to tell, you know, is my problem serious enough to seek out treatment? That's kind of what that's talking about, if that makes sense. And that
Okay.
kind of goes along with the next point. Unfortunately, people are often very motivated to not see themselves as mentally ill. Nobody wants to say, oh yeah, you know, I've got depression, anxiety, PTSD. You know, although many of us do, 1 in 3, 1 in 4 people is going to suffer from one of these disorders at some point in their life. But unfortunately, people don't like to admit it because there is still that stigma, which is something we're working really hard to kind of push back against, but we're still not quite there yet. So people don't want to seek treatment because they don't want to admit that they have a problem, which kind of goes along with also not being really entirely sure if their problem is a problem that could benefit from treatment. So yeah, these are the barriers that are kind of related to how people feel about therapy. You know, they're not really sure if they have a disorder. They don't really want to see themselves as mentally ill. They also aren't really sure about if it would even be helpful. A lot of people think, oh, therapy, like that's just a bunch of garbage. Like it doesn't really mean anything, which is not true, but that's kind of the attitude that a lot of people have. So that's these types of barriers, but then there are also, excuse me, some other barriers listed here as well. This is the other ones I was talking about, the logistical barriers. So even when, so those other ones are kind of why people might not even seek treatment. And then these here are kind of reasons why they might not be able to obtain it even if they want it. So it's really hard to find the time and the money to go get treatment. If you're working, you know, a minimum wage job and you're trying to make money to survive and maybe support your family, then you're not probably going to have money left over for therapy. And even if you did, how are you going to take time off work to get to your therapy session? Right. And, you know, maybe you don't have a vehicle to get to where the therapy takes place. So there are so many other logistical barriers as well. So when you're thinking about barriers, it could be any of the ones listed from these lists. So either here or the stuff that's kind of up there, which is more about like how people view themselves and how they view therapy. Does that kind of make sense?
Is that on this slide too?
On what side? Sorry.
The barriers that you just mentioned on the logistics, the race.
Is it? Is it
it on the slide too?
It should be.
I can't find it there.
It's quite a few after that one. Like it will be slide number 23. So it's a little ways after, because I did talk a bit about culture and geography here too, which I kind of mentioned. So like some people want to see a therapist in the same culture and things like that.
Oh, okay. Thank you.
Can you find the slide 23?
Yes.
Okay. Yeah, they're separated, so it's a little confusing because there's a few of them up there and then a few of them down here. There's a big section about barriers, so they're kind of all over the place within that section. Sorry, that's a little confusing. But yeah, for that question, you're going to want to look at slides 23 and slides 18 will be the main answers for that question number 3. And then a little bit on here too as well. But if I did ask you a question like that, it will probably be more general. Like if I asked you as a short answer, I'd basically say, what are some barriers? And you could list any of those. But as a multiple choice, it would probably be like the basic ones, like, you know, time and money, like they're the big ones, or the cultural match or something like that. So I wouldn't worry too much. You don't have to memorize every single one of them or anything. Did anyone have any other questions?
I have a quick question. Can you go over the biopsychosocial model a little bit?
Definitely. That one is super important for us. It should be somewhere in chapter 15, I'm assuming. Let me see. I like to pull up the slides so that way, you know, after, if you guys want to go back and take a look at it, you know where it is. That's also why I do the numbered slides so that you can refer back to what number they are. Now, granted, when it's in different modules, sometimes the numbers are different, but if you print the one, these are the ones that I'll upload, like with the links to our page, so the number should correspond to your notes if you printed that copy or if you're using that copy. Where are we talking about biopsychosocial? Oh, here we go. Right. So basically all the biopsychosocial model refers to is the fact that if we're looking at mental illness, we know that there are a bunch of different areas that mental illness can develop from, right? So for example, a lot of personality disorders are linked to trauma during childhood. So that would be an environmental factor, right? That's something that's like, it's not part of who they are as a person. It wasn't part of their biology, but it was part of their society, their social environment, right? So that would be kind of the social part of the model. Whereas some people, you know, if your parent has schizophrenia, you have a higher genetic predisposition to having schizophrenia based on that. So that would be the bio part of the model. And then the psycho refers to kind of like the psychological aspect. So for example, the attribution someone makes. So people who are depressed, when something bad happens to them, they tend to think this is because of me, right? They make an internal attribution, you know, this is my fault. They tend to think that it's kind of going to go on forever. So they say, you know, things are never going to get better. And so it's stable. And then they also think of it as, you know, everything is awful. So it's global. So when they have a negative event and they think of it in that way, it makes them feel really hopeless, right? About ever being able to recover. Whereas if a bad thing happens and you're able to say, oh, that wasn't my fault, like, you know, it was out of my control, then that you feel a whole lot better about that event. You know, it doesn't weigh as much on you. So the different types of attributions and ways people think about things can also influence whether or not they're likely to develop a mental illness when, you know, a negative event occurs. So the biopsychosocial model is all about taking all of those different types of aspects, the biological, so the genetic predisposition and the temperament and those things that you're kind of born with, the psychological, which is kind of the way you think about things and how you process information, and then the social, as in the environment you're in and the things that are occurring around you, and blending all three of those different causes together to kind of create any specific instance of mental illness. So it's basically just saying, you know, it's not just about biology. If your parent was depressed, you know, maybe both your parents were depressed at some point, then you have a pretty high genetic risk factor for developing depression, right? So that would be the biological part. But if you have really pleasant social experiences, and if you learn how to think of things in really positive ways that don't blame you, then you might be less likely to develop mental illness. So all three of those factors kind of come together and influence any particular case of a mental illness. Does that make sense?
Yeah, it does.
Yeah, it's a lot. And then we have this one here, which is nice because it basically goes through those three different kind of causes, right? So you can see they use depression as their example. So for biological, you might have genetic influences on neurotransmitter production. So for example, we know that most antidepressants target serotonin, which is a neurotransmitter in our brain, and they try to increase serotonin because we don't have enough. So that might be a genetic part of depression, is not having enough serotonin, maybe. Or, you know, sleep disruption, maybe that's kind of got a genetic cause. So that's contributing to your depression. For psychological, you have your negative self-concept, your pessimism, your negative life experiences. So again, kind of like the pessimism, I guess I did say negative life experiences kind of in the socio-cultural, which it can fit kind of under both. But just that concept and the way you think of bad things that happen and stuff, all of those are the psychological part. And then the socio-cultural would be, you know, not having social support, withdrawing socially, not being able to access the services you need. So there are so many different factors that can contribute to mental illness. And actually, when we talked about it in our classes, we called it the biopsychosocial developmentally informed lens. So we kind of took stage of development into account as well. because of course that can influence how you think about things and what genes are kind of being displayed at any particular time and stuff like that. So you can even kind of go one step further. But the whole basis is just to say that mental illness isn't just caused by one type of factor. There's a bunch of different factors that contribute. That's kind of the general thing to keep in mind there. Sorry, I probably explained some of these things, like over-explained some of these things, because it's just the stuff that I spend all day reading about. So yeah, but that's basically all it refers to. Okay, let's see. Got the chat. I'm assuming, Meryl, when you're talking about GDP, you're meaning GAD, like generalized anxiety disorder? Yes, okay. So Meryl was asking about what the difference between generalized anxiety disorder and panic disorder is, which is a good question. So panic attacks are a really brief, really intense episode of panic, right? I don't know if any of you experienced them, but they usually are over within 10 minutes, like 5 to 10 minutes. But when they hit, it can literally feel like you're dying. So your heart starts racing, you start breathing, you start like heavily, you start sweating, you have a sense of dread, you might feel like things aren't really real anymore, like you just get kind of like overwhelmed. Basically, your body's being flooded by that kind of panicked arousal. Evelina, I did give you the review guide, like this one. Did you see this one? Those would be kind of the major things to focus on. That one's uploaded.
This is the one I meant. I just couldn't find it on the.
Oh, sorry. Yeah, no, it is uploaded. It's just under the still under the review thing, but I think they all go test 1, test 2, test 3, and then this one's called final exam. So it might look kind of funny. It might actually be at the top of the list, but it should be under the course lessons under your review materials. I'm pretty sure I did upload it, didn't I? Now I'm paranoid about it. I double check. Sorry, I will get back to your question in a second, Meryl, because that is a very good question. Just checking. Okay, yeah, so it is there under review materials, but it's at the top of the list because it starts with final exam instead of tests, and they go in alphabetical order. So that might have been why it's a little trickier to find, but it is available on your Moodle page. Okay, yeah, so panic attacks, basically what I just described. There's intense but brief episodes of panic. And panic attacks can occur with or without an anxiety disorder. People can have panic attacks every now and then and not have a disorder at all, right? But panic disorder occurs when you start to have panic attacks and they concern you so much, you're so frightened by them, and you think that, it basically means that you're dying, that you start to dread having more panic attacks. So technically, panic disorder is when you basically fear having unexpected panic attacks. And so a lot of the time you might start to avoid situations where you think a panic attack might be triggered. In severe cases, it can get so bad that because you're terrified of having that panic reaction, you start not leaving your house because you say, you know what, I don't want to go out in public because what if I'm in the middle of a mall and all of a sudden that panic hits and I don't have anyone to help me. And so in that case, when it gets that severe, it can actually turn into another disorder called agoraphobia. So when it starts to generalize, the fear starts to generalize to different areas. So for example, crowded areas or wide open spaces or public transportation. For agoraphobia, you have to have at least 2 of those. Those kind of situations that you basically avoid chronically because you're terrified of it causing that panic reaction. So panic disorder, you have those panic attacks, you've had a few of them already, and they seem to kind of come out of the blue, because you could have a panic attack that's kind of expected. If something really bad happens, you just found out a family member died or something like that, then you might have a panic attack and that might not indicate a disorder at all. That's something that people experience sometimes. But when you start having them out of the blue with no cause that you can figure out. And when you get to the point where you're so afraid of having another one that you start kind of avoiding certain activities and refusing to, go places without like a safe person with you, then that's when it becomes kind of panic disorder, when it starts to interrupt your life because you're so terrified of having that next panic attack. Whereas generalized anxiety disorder is essentially someone who's a chronic worrier. So with generalized anxiety, basically you worry about most things most of the day, like every day. Like you're chronically worried about things. And it might not even be anything in particular. It might be that you just feel awful and you feel anxious and you don't know why. So with generalized anxiety, it's not those really intense, extreme bouts of panic, those really kind of short bursts of super intense anxiety. It's just a general feeling of dread and apprehension most days. And so it can be really, really debilitating, because basically what happens is the person just feels worried and anxious all the time. And when we talked about general adaptation syndrome back in the stress coping and health chapter, if your body is constantly in that kind of high alert and like trying to like figure out what threat's going on, that's using a lot of resources, right? So people who worry chronically, it can be really bad for both their mental and their physical health. So that's kind of generalized anxiety. So generalized, yes, it's definitely more, Evelina, it's under the course lessons, where your notes are. It's in that folder. Like there's a little folder in that folder called review materials. And that's where the topics should be, like where you go to get your notes. So it's in the course lessons folder on the homepage, if that helps. But yeah, so you're welcome. So yeah, generalized anxiety disorder is basically, someone who's kind of a chronic worrier. They're basically dealing with a fairly high level of anxiety more days than not. And it's not that intense bout of panic that feels like you're dying, but it's just a general feeling of apprehension and dread. Whereas, yeah, panic disorder is much more about those super brief, but very, very intense bouts of panic. And you could have generalized anxiety disorder and have panic attacks occasionally. But when you start to dread those panic attacks, you start to fear having another one, that's when it becomes potentially a case of panic disorder. Hopefully that kind of explains the difference there. You are welcome. Does anyone have any other questions specifically about the content? I need my Starbucks this morning. I wasn't expecting you all to pick 1 p.m. So I needed to get up and presentable. If there are no more general questions, I can just pull up the review topics really quickly if you'd like, and just kind of maybe very briefly go through, even point out what they're referring to, because that way I know, like, even if some people were going to watch this afterwards, they might have had questions that we wouldn't have covered, but maybe I can just do a very brief review of it all. Do you think that might be helpful? Oh, good question. So Meryl asked, what's the difference between OCD and OCPD? And that is a good question. I did not know OCPD existed until a couple of years ago. And I think it's really interesting now, because a lot of people who say, oh, I'm so OCD, they're probably exhibiting symptoms that are more characteristic of OCPD, which is obsessive compulsive personality disorder. So OCD, obsessive compulsive disorder, is basically when somebody has really intense obsessions over something. So these intrusive thoughts that they can't get out of their head no matter how hard they try, right? And the compulsion part comes into play because they behave in compulsive ways in terms of completing compulsive actions or engaging in rituals to try to help deal with those obsessions. So there are different categories of OCD. So for example, one of the most common, and you've probably heard of it, is contamination OCD. So people who feel like there are like germs on them all the time and they really need to kind of be clean and everything needs to be clean. And so for example, in that subtype of OCD, the obsessions would center around being contaminated. So, I can't touch this, like I'm going to get germs me. There are germs all over me. They're constantly over me. Like you're getting these intrusive thoughts about, it's unclean. I need to get clean. I need to get clean. Like I'm going to spread disease, I'm going to do whatever. And so they start obsessing over that. And so then the compulsion, the behavior that they engage in to help deal with that obsession would be obsessive cleaning, right? So maybe they go to the bathroom and then they wash their hands 20 times because they don't feel clean enough, because the obsession in their head keeps saying, you know, you need to be more clean. You're not clean enough. You're going to spread germs. You're going to spread disease, da, da, da. And it makes them really, really concerned that they're going to, you know, contaminate other people or contaminate themselves. And so then they engage in that obsessive hand washing or cleaning behavior to try to deal with those obsessions. So that's where it's like obsessive compulsive, because you have the obsessions and you use the compulsion to try to deal with the obsessions. OCPD is a personality disorder in which people tend to like things very kind of neat and very clean and very orderly. That doesn't necessarily mean that they have the severe obsessions and the compulsions. It's more of inherent to their personality. So it's a personality disorder. It's not OCD itself. And the thing is, someone with OCD is quite often very distressed by their thoughts and their compulsions, there's obsessions and compulsions, right? So they don't want to have to clean their hands 50 times after they use the bathroom. That's not, you know, that's distressing to them, having these thoughts of, I'm contaminated, I need to get clean, I need to get clean. Someone with OCPD, it's kind of a part of their personality to be cleanly and to be, I don't know if cleanly is a word, to be clean and to be orderly and have everything neat. And they don't really see anything wrong with that. That's just kind of a part of who they are. So it's not as distressing to them. It's not something that they're going to say, you know, like, oh yeah, I'm just like super, you know, I'm just overwhelmed. I can't stop thinking about all this stuff. It's more kind of inherent to their personality and who they are as a person. And so personality disorders in general can be a lot harder to treat than other types of disorders, because a lot of people with personality disorders don't realize they have them because it's part of their personality. When they were growing up and when their personality was kind of fundamentally being formed, typically something occurred within that period that led to the development of these disorders later down the line. So the personality never fully developed in the way that maybe it should have. And so a lot of the time it can lead to these symptoms, but it can also lead to people being very resistant of a diagnosis. They're like, no, there's nothing wrong with me. I just like things neat, right? Versus someone with OCD is probably going to be like, yeah, there's something wrong with me. I can't stop cleaning this counter 20 times in a row. Does that kind of explain the difference? I find those two very interesting. I actually, yeah, I didn't know that OCPD was a thing. And so when people say, oh, you're so OCD, like if somebody is like super clean and like wants to keep their house in order and all that kind of stuff, they're probably more likely to have OCPD than they are to have OCD. But that's, again, one of those stigmatization and like myths about mental illness in the general public. So yeah, that's a really interesting one to me. So I'm glad you brought that up. Okay. So, and if you do have any more specific questions, feel free to pop them in the chat. I'm just going to pull up that review topics list and see if we can kind of briefly, actually, I'll share the whole screen because that way I can flip back and forth if I want to show you guys some stuff in the notes. So we talked a bit about the biopsychosocial model, some possible critiques of the DSM. You don't have to like super focus on that, but there are quite a few things about the DSM that aren't great. I mean, the thing with the DSM is it's called kind of like the Bible of psychiatry, and it is something that we use. I mean, I have a DSM literally right here. This is the 5th edition, Diagnostic and Statistical Manual of Mental Disorders. And if you look, I don't know if I'll have to find a chapter where I read a bunch, but I do have a bunch of highlighting in here somewhere because I always go a bit nuts with my highlighting. But this contains all the disorders, all the criteria, and it's a great resource. It even lists stuff about, you know, the potential etiology of the disorder. So basically the potential factors that might have contributed to it. It talks about the prevalence rates. It talks about, you know, typical courses of it, you know, whether or not it's like a cyclical disorder, whether it's like an episode and it kind of never really comes back. So there's a lot of really great information, but the main issue with it is it can't be taken as the only tool you use to diagnose clients. You can't just look at the list of symptoms of the DSM and say, okay, you've got 5 out of 8, so therefore you have that disorder. You should always be using it in conjunction with other methods to diagnose. And so some of the critiques are like, well, it can get really confusing sometimes whether something is more of like an everyday problem or a severe mental illness or something like grief that we talked about earlier. There's also like some of the diagnoses in it themselves are a little bit questionable. It's always changing. So like, for example, I can't remember the exact edition, but it was only within maybe the past 40 years, 40, 50 years that homosexuality got taken out of the DSM. So for a long time, homosexuality was literally listed as a mental disorder in the DSM. And so something like that, like clearly we look back at that and it's like, okay, so like what disorders do we have in there now that a few years down the road might be like, why do we ever consider this a disorder? So we still have gender dysphoria in there, which is something that in a lot of cases, people who are trans, they have to be diagnosed with gender dysphoria in order to be able to get their transitional surgeries. And that's a problem, that we have to diagnose them with a mental illness in order for them to be able to transition. So, you know, it's not a perfect resource. It's the best one we have in terms of taking all that information and putting it in one place, but it is constantly revised over time. And it is something we're going to continue to kind of to work on. I've got a chat, I'm going to see. Oh, it wouldn't pop up for me. Darn it. Sometimes when I share the screen, the chats won't work. Let me try again. Oh, there it is. So if they take out some type of mental illness, that means you're not allowed to diagnose that kind of mental illness if they take them out? That's a good question, Meryl. So I think, yeah, Meryl said this one to everyone this time. So yeah, you guys can see it in the chat there, but she said like, so what if they take out some type of mental illness? Does that mean you're not allowed to diagnose that kind of mental illness if they take them out? That one's a little tricky because there are some people who will go back to previous editions to diagnose certain disorders, but I mean, we definitely can't diagnose someone with homosexuality today. We know that is not a mental disorder. So it really depends on the specific disorder. Sometimes certain diagnostic criteria are actually made worse in subsequent editions, like they're even more unclear than they were. So sometimes people will revert back to the older ones, but yeah, generally, if they take it out, the thing with the DSM is like there are codes for each of the disorders, and a lot of insurance companies, especially in the States, the insurance will refuse to pay for treatment if you don't have a diagnostic code associated with your file. So that's another reason why the DSM is not so great sometimes, is because sometimes clinicians will give a client that label and that disorder just so they're able to get their insurance to pay for treatment, even if they don't necessarily fit it. So you couldn't diagnose in that way. Something that's been taken out of the DSM, because it would have to be something in the current edition to have that kind of coverage. But yeah, like most of the ones that are taken out, it's mostly because we've realized that they're not actually disorders, like homosexuality, for example. But obviously we know that's not actually a psychological disorder. So yeah, typically we wouldn't be diagnosing anyone with a disorder that's no longer in the DSM. The personality disorders, I kind of talked a bit about them earlier. So yeah, like the cluster B, those are the ones that it said focus on. Those are the ones the old textbook focused on. Let me just bring them up. I'll bring up the whole table of them. Oh yeah, I guess if you're looking for some more of the critiques for the DSM here. So there's overdiagnosis with some things. This is what I was talking about. The boundaries between the neural problems and mental disorders can be fuzzy, but it does, when used correctly and in conjunction with other assessment tools like diagnostic interviews and things like that, it is considered to help improve the reliability of diagnosis. So it is a good tool. It just got some issues with it that we have to kind of keep in mind. So where are personality disorders? Here we go. So yeah, this is basically, I mean, if you could remember this much about each of them, that would definitely be like sufficient for like a multiple choice type question. You'd be able to recognize them just by knowing like these little descriptions here. If I did ask you a short answer question, I'm not 100% sure what I'm asking you yet. So I am literally saying if I did, because I'm still got to pick which I want to make short answer questions. So I'm not giving anything away, but if I did, like you wouldn't have to describe more than like 2 or 3 of them, like just list a little bit about them. So that would be a couple sentences each. So nothing major. But these guys here, the cluster B, they are the only ones that were in the last book. And those are the ones that I would say, I don't want to say we see them more often in practice. I do know borderline is a pretty common disorder, and it's one of the most devastating disorders in terms of the impact it has on the individual and their relationships and things like that. It comes with a very high risk of suicidality. So that's one of the ones probably of this list we probably see most commonly, would be borderline. Don't quote me on that. What is humanistic and existential psychotherapies? Okay, I'll go over those in 1 second here when we finish some of this. Yeah, we'll go through that because that's at the end of chapter 16, I think. But yeah, for the personality disorders, if you know a little bit about them, like enough to kind of describe or kind of recognize them based on what's listed here. Obviously there is more information on each one, but you don't have to remember all the symptoms for each one. If you could write like a sentence or two about them, like that would be what you need. I just found them really interesting. The whole antisocial personality versus psychopathy debate. You're not going to be really tested on that. Like that's just something that I have a big personal stake in. I wrote a giant final paper on it last semester because I'm really interested in it. So I talked about it quite a bit in the notes, but I mean, you basically just have to know what antisocial personality disorder is for that one. And you know what the definition of psychopathy is. You don't have to know the whole debate because that's kind of more my thing. Yeah, okay. And so we are going to pop to chapter 16 because I was just asked what are existential and humanistic psychotherapies. Oh no, they're not in the end. Yeah, because the end is the biomedical. Whoops. They're somewhere. Oh, they must be in the first module. Oh no, they're there. Okay. Yeah, so basically like humanistic therapy, the way I distinguish humanistic therapy from something like psychoanalysis, because they are still kind of listed under insight therapies, they're all kind of types of insight therapy because they focus on, you know, the person learning more about themselves and their abilities. And in Freud's case, in psychoanalysis, it's more about learning about their past experiences and stuff and like their childhood and how that impacted them. He was very much like all issues in adulthood stem from childhood. Either like traumas or needs not being met or whatever. He was very big into that. And so his was much more looking at the past in that way, whereas humanistic therapy is a lot about kind of looking inside yourself and realizing the strengths you have and, you know, the potential we have for free will. And so when humanistic therapy became a thing, it was said to be much more positive. So with psychoanalysis, it's very much focused on like, what are the negative unconscious biases and desires and events you repressed from your childhood that are influencing your current psychopathology. Whereas humanistic therapy is like, you know, let's look at what makes humans different. We're going to focus on consciousness rather than unconsciousness and look at the fact that humans have free will. Humans are able to use, you know, their cognitive abilities in ways that other animals aren't. Like, and so it's very much almost more empowerment rather than like looking at all kind of the negatives. So you can see that here in terms when it contrasts psychoanalytic and humanistic. And one of the major things in humanistic therapy, there was someone named Carl Rogers, who was one of the first humanistic psychotherapists, and he talked a lot about unconditional positive regard. So someone who's a humanistic psychotherapist always treats their client positively. They will never take away their, not, I won't say affection because that sounds weird, but you know, they don't judge. They open themselves up and allow their client to tell them anything that they can think of without judging them and you know, saying, okay, you know, I don't like you anymore because of what you just told me. Even if they tell you something bad, you say, you know, I don't like what you did, but I still value you as a person. So that unconditional positive regard allows people to feel comfortable enough to kind of explore themselves without fear of, you know, coming up with something bad and then being like punished or something like that. So that was a really big thing with humanistic psychotherapy. Existential therapies. So that one focuses more on the importance of facing painful experiences in life. So, you know, the fact that like existential is kind of thinking about our existence, right? So, you know, what is our purpose? Like, why are we here? And like facing death and saying, you know, I understand that as a part of human experience, I will die, and kind of coming to terms with that. So humanistic therapists are kind of focused on becoming a better person and learning more about yourself and kind of self-actualizing, becoming that best person you could be. Whereas existential therapists are kind of more about, you have to face your fears and face the harsh realities of life to kind of grow. Excuse me. Can't stop coughing. So that would kind of be the big difference there. So yeah, Carl Rogers, he called it client-centered therapy. So it was a version of humanistic psychotherapy. And so he's very much, people have unique abilities and things that will allow them to solve their own problems and make their own decisions and reach their full potential. And so again, he was very much, we should treat our clients with unconditional positive regard, because he felt that a lot of the issues that one might have developed during childhood or while they were growing up was based on the fact that they had conditions of worth imposed upon them. And basically all that means is that they were only, say, worth something to their parents, or they were only valued by their parents or the people who were caring for them when they did what the parents asked them to do or what the guardian asked them to do. If they did stuff they weren't supposed to, the guardian would kind of take away that love and affection. And so Carl Rogers would say that's what those conditions of worth. So you're only worth something, you're only, good to me if you act a certain way and think certain things and things like that. Those conditions of worth are what he would say contribute to a lot of the different psychological illness that we see. And so by treating someone with unconditional positive regard, we can kind of help reverse those associations. Hopefully that makes sense. You won't need to explain these in like great detail or anything. It will be more so just kind of recognizing them in a multiple choice, most likely. There are other things that I could ask you about for a short answer for this question or for this chapter. So just kind of understanding, humanists focus on the positive, those conditions, that unconditional positive regard, reaching full potential, and existential focus on, we have to face the negative realities as well in order to live our best life. Those would kind of be the one-line summary. We don't really learn a lot about these in school. Like at this point, at least in my clinical program, we almost exclusively focus on cognitive behavioral therapy at this point. Like I've taken 2 intervention courses this semester. We did principles of adult intervention and principles of child and adolescent intervention, and both of them focused on CBT and DBT, which is dialectical behavior therapy, which is a kind of a type of cognitive behavioral approach. It's specifically designed for people with borderline personality disorder. We learned very briefly about some of these things. Like we talked about, obviously any type of therapy, you should have that unconditional positive regard. So we take aspects from these other types of therapies. And, psychoanalysis, like we take the ideas of like transference. That's something that we still talk about in resistance, but we mostly focus on a cognitive behavioral approach, because if you look at the research evidence right now, cognitive behavioral therapies do have the most to back them up in terms of their ability to be effective to treat almost every type of mental illness. So typically we do focus on more of a cognitive behavioral approach. And I would imagine that's typical for most programs these days. Just in case you were wondering. Sorry, I talk about this stuff a lot. Okay, what else do we have? Yeah, so psychopathy and antipersonal social personality disorder. You don't need to know a ton about that. That's just kind of more my thing, but you should know the definitions of each of them. Dissociative disorders, there's not a ton about them. If I were to pick one to focus on, it would be dissociative identity disorder, because it is so controversial. So I do have quite a big section about that in the notes. If you look, let's find it for you so you can see what slide it's on. Yeah, so we talk basically dissociative disorders start here. So if you know like the one-line description of these, that would be good if they came up in like a multiple choice or something. The one that you probably want to focus on would be dissociative identity disorder, also known as multiple personality disorder, because that's the one that's most controversial. So there do seem to be some legitimate cases of DID, but the problem is there were a lot of cases that weren't legitimate and were proven to be hoaxes, that people basically kind of either were faking it, or the therapist took a vulnerable individual who was trying to figure out what was wrong with them and kind of convinced them that they had dissociative identity disorder. So, multiple personalities, those alters. And so a lot of the cases of it, like it kind of exploded. There were like only a couple hundred in years and years, and all of a sudden there were thousands of cases because it gained popularity and people were talking about it in the media and stuff, and like everyone wanted to treat a patient with it because it was so kind of new and controversial. And unfortunately, that may have led to people basically creating these cases in their clients. So it is very rare. It actually only affects about 1%. But there has been that really big controversy over like, is it real at all? Because there were so many cases that were so convincingly faked that it kind of makes you question it doesn't even exist. So like I would stand on the side of saying it does, but it's way, way more rarer than anyone would have thought, because a lot of the cases that we saw weren't actually legitimate. So there's only 79 documented cases overall by 1970, but within the next 28 years, there were over 40,000 reported cases. So it's like, kind of sketchy. Also, about 80% of the patients who were diagnosed with it were unaware of having it before they began therapy. So it really seemed like the therapist said, well, have you considered that you might have this disorder? And then they tell the patient about it, and the patient's like, I don't know, maybe. And they kind of become convinced that they do, which unfortunately can happen with vulnerable patients. So that's a really interesting one. But yeah, you don't have to know like every detail, but if you were to focus on one of them, I would say focus on dissociative identity disorder. Get another chat. Oh, I don't know why. Such a hard time opening the chat one. There we go. That is a good question, Meryl. Does the Split movie and the Glass movie really portray or kind of give justice to what DID really is? Actually, I liked those movies a lot. I was actually just talking to my friend. I have my friend over here today, and she's one of my colleagues. She's in my, or one of my, I don't know if they're colleagues, if they're students, but whatever. She's in my cohort for my program. And Glass popped up on Netflix, because it's on Netflix now. And I was like, that's really interesting, because they do kind of display the characteristics of DID well, in terms of like the switching between the alters and things like that. But there's definitely a supernatural element to those movies, like the fact that he's like climbing on like the ceiling and stuff as one of his alters. Like, yeah, you can't do stuff like that. So there was definitely some like supernatural / like superhero components to that movie, like not really based in reality. But at the same time, they did have a really interesting portrayal of dissociative identity disorder. I mean, I've obviously never treated someone with it. It is very rare, and like it's really hard to tell even when the cases are real or fake. So I can't tell you for sure, but I would imagine it is similar. I have talked to people occasionally who've been diagnosed with DID on the phone lines and things like that. We don't really talk a lot about the alters and stuff, but it does seem to be kind of in line. Yeah, so a lot of the time, like, and I know we're getting kind of off topic now, but a lot of the time with dissociative identity disorder, they'll say that some of the alters developed to basically help protect the person. So for example, if there was somebody who dealt with a lot of trauma in childhood and they were being abused and whatever, they might develop an alternate personality to kind of protect themselves from having to deal with that abuse. So there might be one of the alters who's kind of like the parent almost, who kind of steps in and like takes over and tries to help them manage their problems and kind of be able to repress some things that have happened to them and stuff. So it does seem like they can kind of switch very rapidly. You will see if you look up documentaries and stuff, but again, like I can't tell you which ones are legitimate because so many of them have been debunked. But it does seem that you can switch pretty quickly from one to the other. And a lot of the time they will also induce them using like hypnotic techniques and stuff, which again, a little bit more sketchy. But yeah, it's a very interesting disorder. I don't know that much about it. It's something that I need to study more, but I watched a show, and again, not a perfect representation, but there was a show called The United States of Tara, and it was years ago. Like I think I watched it in like my undergrad. But that one displayed dissociative identity disorder really in a really interesting manner. There was this woman who had multiple personalities, and one was like this like trucker, and another one was essentially a pure representation of her id. So if you remember the id from the personality chapter, it's that kind of most primal part of like your personality that just basically wants what it wants and doesn't care about morals and things like that. So that was a really interesting alter that she had in that show. But again, don't know if it's like a really realistic portrayal, but I did enjoy that show, The United States of Tara. So yeah, okay, well, we'll stop there with that one because again, I could talk about this stuff all day, but I want to see if we can get through most of the stuff that we have on this guide. Anxiety disorders, probably won't really go through a lot of those. We already talked about the difference between GAD and panic. Phobias, you kind of should know, which is obviously just like a very extreme fear of something. What other ones did we talk about? I can't even remember. Generalized anxiety, panic disorder, phobia. Okay, so that's the three. So we already talked about these two and the difference between them. And like I said, sometimes when panic disorder becomes so extreme that people refuse to leave their homes, or they completely avoid certain situations because they're so scared of those panic attacks occurring, that's when it becomes agoraphobia. So a small percentage of, actually quite a large percentage really, of the people who have panic disorder eventually develop agoraphobia. You can have agoraphobia without panic disorder, but it's not as common. Phobias, so basically really extreme irrational fear of something. Social anxiety disorder actually used to be called social phobia. I forgot about this one, which is ironic because I treated a patient with social anxiety disorder this semester. I say that with air quotes because it was like a person acting as a patient, but they were like trained really well to act out the symptoms. And so I had to basically make up my own course of treatment for them and implement it through Zoom. So social anxiety it used to be called social phobia because it is kind of like a very extreme form of phobia, but it relates to being judged by other people or being embarrassed or humiliated in public. So you can have it with or without like the performance specifier, which means you're really scared of getting up like in front of people and like, giving a speech or something like that. But basically the main hallmark of the disorder is that you tend to avoid most social situations because you're afraid of being judged or making a bad impression, or embarrassing yourself in some way. So they tend to kind of use a lot of safety behaviors. So they might go to a party and drink a bunch of drinks before talking to someone because that makes them feel less, and more inhibited, however way that word works. I don't know, I'm not going to think about it right now, but they loosen up and they're able to actually socialize and things like that. Sometimes they'll, avoid making eye contact when they're having conversations. They try to develop exit strategies for if they're out in public and they start to get, embarrassed or whatever, they can like leave right away. So it can make it really hard for them to live their life normally. If you think about trying to avoid every type of social interaction, that would be impossible, right? So for example, my patient was terrified to talk to his professors, right? He was just like, I can't. He's like, I can't ask them questions. Like he didn't even like being in class with his camera on. He'd get really anxious. Like he had a really hard time even just hanging out with his friends on Zoom to play video games. Like it was, so you get a lot of different symptoms, but they're all typically related to social situations and perceived judgment or being embarrassed in front of other people. So we use exposure to treat almost all anxiety disorders. And then obsessive compulsive, I already went over this one. It's not considered technically an anxiety disorder anymore. So in the DSM-5, it's actually in its own category of obsessive compulsive disorders. But it used to be categorized as an anxiety disorder because of course those obsessions come with a lot of anxiety, right? But now it's its own kind of class. And you don't really need to talk about PTSD. It's not in this textbook for some reason, or it's very little in this textbook. So if you see I've got my asterisks here, that means I added this in from an old textbook. But yeah, those would be the ones to know. Social anxiety, phobia, panic disorder, and generalized anxiety. Won't go through that one. I already went through it. Obsessive compulsive disorder, depression, and bipolar. So those would be the only mood disorders that we really cover in this course. There aren't that many mood disorders, honestly, but there are a few more. But basically, with mood disorders, you can have two different poles, right? You have like the lowest low and you have the highest high that you could have in terms of your mood. So the lowest low would be depression, the highest high would be mania, right? And so that's why bipolar disorder is called bipolar, because you get both aspects of those poles, right? You get the highest high and the lowest low, and they kind of alternate. So typically the most common mood disorder we talk about is depression. So just having those periods of the lowest low. So you can have episodes, you can have major depressive disorder and have episodes. They have to last for at least 2 weeks at a time, and you have to fit so many symptoms within that time frame. There's a bunch of different symptoms to choose from. So issues with sleeping, issues with eating, psychomotor agitation, so being really fidgety and stuff, feelings of like low mood, sometimes suicidality. Sometimes you can have kind of issues with kind of not quite feeling real, like depersonalization stuff. There's so many different symptoms, but to be diagnosed with major depressive disorder, you have to have at least a 2-week period when so many of those symptoms are available throughout that entire period. And then you would be described as having a major depressive episode. So once you've had a major depressive episode, you could be diagnosed with major depressive disorder. And so it is pretty cyclical. So it will kind of like, you might have an episode, you might not have another one for like 2 years, but then you might have another one again. Some people have one major depressive episode and never again in their life. But most people do have at least 2. So yeah, they are some of the most common disorders. And so that's kind of a bit about depression, what depression is. But then bipolar disorder is when typically you have the depressive episodes as well. You don't technically have to be diagnosed with bipolar 1, but typically you've had at least one depressive episode, but you also have episodes of mania. So if depression is the lowest low mood, mania is the highest high mood. And a lot of people think of it, okay, what's so bad about being happy? But the problem is people who are in a manic episode, like they'll go without sleep, they'll take a bunch of risks, they kind of feel invincible, they just feel like they can do anything, they might spend a ton of money or engage in risky behaviors like gambling or unprotected sex and things like that. So the manic episodes can actually be kind of more dangerous at times. They might take drugs, they just feel like they're invincible, they talk fast, they behave impulsively. And a lot of the time, it's not even the manic episode itself that's so dangerous, it's the coming down from the manic episode. Because once you've been at that highest high and you come back down, especially if you go into a subsequent depressive episode, that makes that lowest low way worse, right? So bipolar is when you have typically both ends of the spectrum. So bipolar 1, to be diagnosed with bipolar 1, you have to have at least one full manic episode. So it has to be at least 4 days of like the manic symptoms. It may even include hospitalization in some cases. Some manic symptoms can even become kind of psychotic in terms of like having delusions and things like that. So sometimes they do warrant hospitalization. And so for bipolar 1, you basically have to have one full manic episode with or without depressive episodes. For bipolar 2, you have to have at least one hypomanic episode. So it doesn't have to be the highest high, but it has to be very close. Like you have to be exhibiting some of those symptoms for a bit of a shorter period of time. And then you also have to have had depressive episodes as well. So that's kind of the distinction. Again, I'm sorry, I'm getting way too into this. I'm not going to ask you about the difference between bipolar 1 and 2. I didn't even cover it in the notes, but that's basically bipolar. You can think that there's either mania or hypomania involved. Whereas with depression, it's just depressive episodes. And you can also have things like persistent depressive disorder, which is when you're just kind of generally feeling kind of depressed for like a 2-year or longer period. So you might not meet the full criteria for a major depressive episode, but you're still having that low mood and those feelings of, loss of interest in things you once enjoyed and stuff like that for like a very prolonged period. But for the purpose of this, honestly, I didn't talk about any of those. I'm sorry. I'm just rambling at this point. I get so excited about this stuff. But yeah, just no major depression and bipolar. That's the only 2 I talked about in the notes. So yeah, that's basically the lowest low. Bipolar contains those periods of mania or hypomania. So you get the highest highs and typically the lowest lows too.
I have a question. I have a question on chapter 16.
Okay.
You asked us to describe some of the major techniques. You now put in bracket exposure and aversive conditioning.
Right.
So yeah, I can't see the one for exposure on the slide, but I saw the one for aversive conditioning there. Can you please go over that? Yeah, it's on 38.
Oh yeah, aversive conditioning. So there is, I think, exposure. It talks about exposure. Oh, okay. I see what's happening. So I am talking about exposure here, but I didn't call it exposure right. I did talk about exposure in chapter 15 as well. I'll show you where they both are, because that I didn't explain it in as much detail in chapter 16 because I'd already covered it in here a little bit. But yeah, so basically exposure is when you're repeatedly exposing people to whatever it is they're scared of or whatever it is that causes them anxiety. So that's the little piece on it there. But then on this slide, when it talks about systematic desensitization and flooding, those are exposure techniques. I should have kind of restated it here, but it does say like systematic desensitization is gradual exposure to a feared stimulus or situation is coupled with relaxation training. So it is, these are both exposure techniques right here. We don't really use flooding very often. That would basically be like if someone's scared of spiders, you throw them in a room with spiders and lock the door. That wouldn't be very nice. So we don't usually use that one. We usually use something more systematic. So, you know, they work up through like the exposure hierarchy. So you start with the thing that they're least scared of. So maybe looking at pictures of spiders, and then maybe they watch a video of spiders, and then maybe they're in a room with a spider in a cage. And so it kind of is very slow like that. But those would be the exposure techniques here. And then this right here is like basically an example of that systematic desensitization. So basically like, yeah, these are the exposure techniques, but sorry, you're right. I didn't actually define exposure here because I talked about it briefly back. What slide was that? I'll let you know. On 48 of chapter 15. And then, yeah, the aversive conditioning. Well, this is also exposure, virtual reality exposure. So sometimes, like, obviously, if someone's scared of spiders, well, you can expose them to spiders over time, like, you know, like kind of slowly work your way up. If somebody is having PTSD flashbacks from a war zone, well, you can't throw them back in a war zone to expose them to it, right? So in that case, sometimes we use virtual reality instead. So instead of really putting them back into a war zone, which would be unethical and we just can't do that, we would use like virtual reality. So they put a headset on that would look like they were there, but they weren't actually in that zone. And our technology is getting a lot better for that. So it is being used more and more commonly. But yeah, so those three slides here are all exposure. And then aversive conditioning is the only other real behavioral technique it talks about. I was actually talking to some of my my cohort, like the students who are in my program with me. I'm like, for behavioral techniques, they only talk about exposure and aversive conditioning. There are so many other behavioral techniques, but for your purposes, those are the only two you really need to know. Yeah, so with that one, you basically pair something they don't want to do with something negative. So you're creating that negative association. So if somebody drinks a lot and they take a pill that makes them sick every time they drink, then they start associating drinking with being sick, and then they will hopefully stop drinking. So that one's kind of an interesting one. But that is a good question. I apologize. I probably should have put the word exposure somewhere on here. But yeah, these are the exposure techniques on these three slides. Okay, so we just talked about depression and bipolar. Yeah, the common types of attributions. I talked about this a little bit earlier. There we go. This is basically just making those global, stable, and internal attributions for negative events. So again, if someone is depressed, they tend to be more likely if something bad happens to blame it on themselves. So he lost his keys. I'm so stupid. How could I lose my keys? I'm such a dummy, right? So blaming it on himself. Stable, I'm always going to do things like this. I'm just an idiot. This is just the way I am. It's never going to get any better. And then global, everything I do is a disaster, right? So people who make those kind of attributions, the internal, stable, and global attributions when bad things happen, are much more likely to become depressed because they're thinking of things in a very pessimistic way. What was our next question? Schizophrenia. So there's a whole module on schizophrenia, which I was pretty excited about because I think schizophrenia is fascinating. But you don't need to know everything there. There's a lot of information. Yeah, so I always use this quote whenever I'm talking to people with schizophrenia. And I use it when I'm telling people why it interests me so much, because it's like the cancer of mental illness, in that there are so many different varieties and different presentations of schizophrenia that like no two people suffering from it are exactly alike. And that's what I find fascinating, but also what makes it very difficult to treat because each case is different. So essentially it is a brain disease. It's very biologically based, and it causes people to experience splits from reality. And so a lot of people refer to people who have multiple personalities, which is dissociative identity disorder, as being schizo, right? That's a big thing in movies and stuff, and that's one of my like pet peeves, because schizophrenia is not multiple personalities, and it never was, but that's what people have an idea of when they hear the word schizophrenia, because unfortunately we have that negative stigma. But it's basically more of a break from reality. So they're unable to tell what's reality and what's not. It's a type of psychotic disorder, which is all about kind of that split from reality. So they can have trouble, speaking and expressing emotions and things like that. They could be have problems with attention and memory. They can experience really bad hallucinations and delusions. So there's a lot of different symptoms of schizophrenia. So the main things to focus probably would be kind of understanding that there are 3 stages typically. So prodromal is kind of like when it's about to begin, like it's kind of the warning signs that an impending schizophrenic episode is going to occur. The person starts to kind of withdraw. They might start to get confused more easily, not be so motivated to do things. The active stage is when the person is experiencing a lot of those positive symptoms. So the delusions, the hallucinations, disorganized thinking patterns, and then residual is when those symptoms subside. So they may actually be in full remission and kind of able to function normally, or they may be still a little bit withdrawn and having trouble concentrating, but they're not really actively having those major positive symptoms occurring. Positive and negative symptoms is a big distinction to know. So when we're talking about a positive symptom, it doesn't mean it's good. It means that it's something that's there that wouldn't normally be there. So having hallucination is a positive symptom because normally people don't have hallucinations. Having a delusion is a positive symptom because normally people don't have delusions. Negative symptoms would be when things that are typically there aren't. So if somebody loses their ability to kind of communicate emotionally and kind of experience emotions in the same way that people typically would, that will be a negative symptom because you're taking away something that was typically there. Hallucinations are pretty common. Hearing voices is very common in schizophrenia. The visual hallucinations are a lot more rare, but auditory hallucinations are quite common. Delusions would basically be believing something that isn't based in reality. You might believe you're like a celebrity. You might believe that you were like sent from God to save the universe. You might believe that you're a genius and you have like the answer to like some crazy mathematical or scientific question. A lot of those would be known as delusions of grandeur. So people start to believe that they're much more important or talented than they really are. And there can also be disorganized behavior when people they're just not able to function as they typically would in terms of cooking, socializing, thinking, all of those different domains of functioning. The subtypes aren't actually still listed in the DSM, but I thought they were really interesting and they kind of help organize what some of the typical kind of presentations of schizophrenia would look like. So paranoid, of course, is characterized by those more paranoid beliefs, like delusions that people are out to get them, people are watching them, people are following them. It might include delusion of grandeur, thinking like, I'm the one who has like, the secret, I can solve this mystery, but like people are going to try to take it away from me, So it's characterized obviously by being very paranoid. Disorganized is when it's just very difficult to function in terms of speech, thoughts, behaviors, doing things that are really kind of unpredictable, poorly integrated into reality, maybe incoherent. Catatonic is much more of like the negative symptoms of schizophrenia. So they might basically just like withdraw completely and just sit and rock back and forth for hours and not say anything or do anything. And they may also kind of do things like repetitively, like over and over again without having any like meaning to them. Undifferentiated basically just means that they're exhibiting a variety of symptoms from the different categories. And then residual would basically be kind of similar to that residual stage. So they could either be kind of transitioning into an episode or they could be in remission and not really experiencing any symptoms at the moment. So that's kind of really all you need to know for schizophrenia. And this stuff, I kept this in here for you guys to look at if you were interested in it, because I do think addiction is interesting as well. And it is something that is in the DSM, substance use disorder. So I want to keep it in if anyone was interested, but obviously I won't be testing you on any of this stuff. That's just more for your own knowledge if you wanted to review it. That is chapter 15. Sorry, I'm trying to go kind of fast because I know we're already an hour and 17 minutes in, and I have a session at 3 to get to. So I don't want to take too much more time. Does anyone have any questions on any of that chapter 15 stuff that wasn't answered just then? Okay, we'll briefly go through this stuff. We've answered a bunch of these questions already, so I'm not probably going to go back and forth to the notes as often. The difference between psychologists, psychiatrists, and counselors. Actually, I made another presentation the other day, which might make this kind of clear for you. I did a what can you do with a psych degree presentation for the psych department. And one of the things that I did talk about in that presentation was the difference between psychologists, psychiatrists, counselors, all that kind of stuff. And I made a little slide for it. So let me just see if I can pop that open for you. Rainbow, it's very pretty. Right. So this is kind of my little cheat guide here. So a counselor is someone that has typically a master's minimum. They sometimes have a doctorate. Most people who are counselors are practicing with like a master's of counseling. Or sometimes a master's of education in counseling psychology, but they would be more likely to be treating kind of your everyday problems. Not so much, severe mental illness, like maybe some depression, anxiety, but typically not, like psychosis and things like that. So they are like, counselors are probably much more common than like the other two when we're talking about counselors versus clinical psychologists, psychiatrists. Clinical psychologist, which is what I'm in a program for, is someone who's completed at least a doctorate. So whereas counselors typically have that master's degree, they focus on more everyday problems and milder mental illness. Somebody with a clinical psychology degree has a doctorate. So I'm doing a PsyD program, a doctorate of psychology. You can also do PhD, EdDs, but you would have like a doctorate level of degree. And you are going to be more responsible for like assessment and diagnosis as well as treating disorders. So we're the ones who are really heavily trained to kind of use the DSM, use the diagnostic interviews and all those different methods to be able to assess a patient really well and kind of create a case conceptualization for them and use that to kind of inform our treatment plan. So we are going to be we wouldn't be dealing with everyday problems really at all, like something like grief or like marriage issues and stuff like that. Typically not the realm of a psychologist. That's probably more the realm of a counselor. Some might focus in things like that, but typically it is more mental illness specific. And so it could range in treating, depression, anxiety, right up to treating things like schizophrenia and personality disorders. But they are much more trained in kind of assessment and diagnosis, as well as treatment, whereas counselors, it's more kind of focused on the treatment. Psychiatrists have an actual medical degree. So they have gone to medical school and then completed a residency in psychiatry. They are the only one of the three that can prescribe medication because they are the only ones who are actual medical doctors. In some states, they have started to allow clinical psychologists to prescribe if they have specific certification. You can go do like extra courses and stuff, which I think is not necessarily a bad idea because we are really trained in the different mental illness and the treatments, and we even take courses in psychopharmacology in our degrees. So I think that, with the proper training, it might make sense to have them be able to prescribe, just because psychiatrists, there's so few of them and they are so busy. They are just kind of overrun a lot of the time. So, but they would be the ones who can prescribe medication, and they would be the ones probably more likely to be treating the most severe types of mental illness because they're the ones who can treat them with a blend of therapy and with medications. And then you can also do things like clinical social work and psychiatric nursing, which you can kind of counsel with or do therapy with. But those are not so much focused on, and like for the sake of our course, we're just kind of mostly focusing on these first three. I just did this up for anyone who wanted to come and talk about kind of psychological practice. I did a presentation last week, so this is kind of how I organize them all. What are empirically supported treatments? Very short form, they are treatments that are backed by scientific evidence. Why can treatments be so difficult to evaluate? Well, you can imagine psychotherapy is a very personal thing, right? It depends a lot on who the person is and whether they have empathy and whether they have the ability to connect with people. There's a lot of different factors that go into psychotherapy that aren't necessarily kind of scientifically measurable. So there are a lot of counselors and, you know, psychologists who would say, well, you can't really adequately scientifically measure what therapy is and how it functions. But I think in general, you are able to view these things empirically and try to see what support there is for them. So I would argue that, you know, we should still be using evidence-based treatments as often as we can. Potential barriers to treatment, we already went through some of those. Insight therapies, I think, yeah, that was, okay, so it was from the second one, the barriers. Insight therapy, so I talked a bit about those. Those are the ones that are kind of looking inside yourself and trying to find out new things about yourself, and that would be like Freud's psychoanalysis and the psychodynamic theories, but also the things like humanistic and existential therapies as well. The 4 major techniques that came out of psychoanalysis, I will pull those up because those are pretty important. And again, psychoanalysis, because it is all based on the unconscious, a lot of it isn't really heavily backed up by the scientific evidence. So a lot of psychoanalysts will probably say we shouldn't always look for scientific evidence, but we do still use some of those, these techniques in pretty much any kind of therapy. So free association is kind of one of the hallmarks of psychoanalysis, basically just sitting with the client and allowing them to kind of say whatever comes to mind, not really questioning them, just kind of getting them to talk until they kind of hit upon something that might be important, and then the therapist can kind of jump in and be like, okay, you said this, let's kind of explore that more. So it's a very kind of like open technique. So very different than something like cognitive behavioral therapy, like we're learning how to do, which is very much like problem-based, problem-focused. You know, we're going to try to solve these things. Free association is basically just say whatever comes to your mind, and eventually you might say something important. So not so much used outside of psychoanalysis. Dream analysis, that's probably of the 4 the least. Well, and if we can say that any of them are really scientifically supported, like dream analysis has no scientific support really. So basically Freud was very big on looking at the content of your dream and basically the manifest content, so what you're actually dreaming about, what kind of latent content was associated with that. So what kind of you know, underlying desires and stuff were there that could be explained by what's coming out in your dreams, like the symbolism. So obviously not something that has very much scientific support, but it was something that Freud was very into, and he was the guy who created psychoanalysis. We have resistance, and this one is definitely something you do see in therapy, in any kind of therapy, is when the patient, the client, starts to engage in strategies to kind of pull away from the therapist. So for example, they might start canceling their appointments, or they might kind of make jokes to deflect from the seriousness of the situation. A lot of the time when they're doing that, it's because you're getting close to hitting on something really important. And so that's what psychoanalysis would say, that resistance usually comes up when the person's trying to avoid talking about something, or trying to avoid you getting to like kind of the root of their issue. So I don't know how much we believe in all that, but we definitely do see resistance. When therapy starts to get hard and challenge the client, clients will often kind of pull back. But in psychoanalysis, it really is seen as a promising signal that the unconscious motives are going to soon be revealed. And then the 4th, and probably the most important to any kind of therapy, is transference, which is when the client directs certain patterns of their experiences on the therapist. So for example, if the person had kind of hidden sexual feelings towards somebody in their life, they might start to become attracted to the therapist. Or if they were abused by their parent as a child, they might start to kind of almost fear the therapist, like kind of treat them like they were their parent or they were their guardian. And so in that case, when the client kind of transfers those emotions onto the therapist, it's then the therapist's job to understand where that's coming from and actually kind of actively address that in therapy and talk about it with them in order to hopefully help kind of alleviate that concern. So transference is something that we talk about in almost any kind of therapy because it does happen. Clients do tend to kind of transfer some of their feelings kind of unconsciously a lot of the time onto the therapist that they're working with. So yeah, those are the 4 techniques. Of the four, the one that, we probably most talk about in other forms of therapy would be the transference. We talked about humanistic and existential. We talked about behavioral therapies. So they're basically anything that's based on those principles of learning that we talked about in chapter 6 last semester. So classical conditioning, operant conditioning, using reinforcements and punishments, using association with things. Those are all the behavioral therapies. And so the techniques we just talked about them were the exposure and the aversive conditioning. Cognitive behavioral therapy blends those behavioral techniques with techniques that focus on the thoughts and the content of your thoughts and your beliefs and things like that. And sorry, I'm going a bit fast now because I know we're almost at 2:30. And I think there's only 8 people left here. So I want to try to finish up soon. Mindfulness-based cognitive behavioral therapy is when we start to add elements of mindfulness, which is basically focusing on the present moment and present awareness. So a lot of meditative techniques would be considered kind of mindfulness techniques. So being in the here and now and accepting your thoughts and emotions as they occur, all of that stuff is kind of related to mindfulness. So that just adds kind of an extra element onto traditional CBT, which focuses on, identifying negative cognitions and challenging them, identifying negative behaviors and kind of reconditioning them. And so the mindfulness kind of brings in that aspect of kind of acceptance and just awareness of how you're feeling and things like that. Pros and cons of the major types of therapy. I won't really get into them, but there is an actual slide here for that somewhere. There's the cognitive.
Slide 49.
Oh, 49, thank you. Yes, so basically when I say pros and cons, I'm just talking about what's here. So you don't need to specify talking about, mindfulness-based CBT and things like that. It's just basically comparing insight therapies to the behavioral and cognitive therapies to the group and family therapies. So if you can kind of remember the basics from this table, that will be enough to answer that question.
Please, before you go, where we talked about cognitive behavioral therapy, you asked us to how can we apply this therapy to depression?
Oh, I think I just saw a message there that I hadn't seen before. Oh, yes. Oh, sorry, Melissa. Oh my goodness, and Meryl. I'm sorry, everyone. For some reason, I don't know if you're still here. Let me just stop sharing for a second. Okay, so Melissa and Meryl are still here. I just noticed I had 2 messages from you both from one was 25 minutes ago, one was 13. They didn't pop up for some reason. There really is, so Meryl asked, what's the difference between major depression and depression? Is there severe depression and mild depression? There actually are, but you don't need to get into that. But major depressive disorder is what most people diagnosed with depression will be diagnosed with. If you've had a major depressive episode, you'd be diagnosed with major depressive disorder. The main difference between the main other one that we talk about a lot is persistent depressive disorder, which was formerly known as dysthymia. So just basically feeling kind of mildly depressed, but for 2 years or more. So I know it doesn't really answer that question, but there isn't a difference really between major depression and depression. When people talk about depression, they're mostly talking about major depressive disorder. Within the depressive disorders, we have basically major depression and persistent depressive disorder. But yeah, there are obviously some people might hit, I think there's 13 symptoms of depression maybe. So some people might hit all 13. Some people might only hit 8. So there are definitely differences in severity as well, but that's not something we really focus on as much as have they qualified for having a major depressive episode, they had this certain amount of symptoms for a 2-week or longer period. And then Melissa asked about sociopaths and psychopaths. I love talking about that stuff. Okay, I'm not going to go too into it because I know I'm not going to test you on anything really about it, but that was when we were talking about the personality disorders. So there's something called antisocial personality disorder, and that is what is basically taken over for psychopathy in the DSM. So someone who is a psychopath and sociopaths, the difference between the word psychopath and sociopath is not as clear. My understanding is a sociopath has kind of a deadened capacity for emotion. So they don't have as much of a capacity for emotion as a typical person, whereas a psychopath has a lack of emotional capability. So they can't feel guilt, they can't feel shame, they can't feel fear. And typically when I hear of sociopaths, people are talking Sorry?
Oh, no, that's okay. Sorry about that.
That's okay. Yeah, so like typically when people talk about sociopaths, I think they talk about a little less severe, like they have some emotional capability, but not as much. Whereas a true psychopath would have like a complete lack of emotional capability. The main distinction I talked about was a psychopath versus someone with antisocial personality disorder. Because essentially the DSM replaced psychopathy with antisocial personality disorder. But antisocial personality disorder is specifically characterized by a pattern of criminal and reckless activity that begins in childhood and persists throughout life. So basically like blatant disregard for the safety of others. So engaging in like criminal activities and stuff like that, that would be kind of the hallmark of ASPD, like antisocial personality disorder. Whereas a psychopath has a lack of emotional capability, but that doesn't necessarily mean that they're going to engage in criminal activity. They could, because they won't feel bad about it, because they don't feel guilt or shame, but they won't necessarily always engage in reckless and criminal activity like someone with antisocial personality disorder would. When the two converge, when you have somebody who has psychopathy and ASPD, that's when you would get that most violent, sadistic, type of killer imaginable, because not only don't they care about others, they've been committing crimes for years, they have a disregard for the safety of others, they also don't have that emotional capacity to feel guilt or remorse. So that would be kind of the most dangerous combination. But the fact is, most people with antisocial personality disorder who are kind of engaging in that criminal activity and reckless activity and disregard for other safety, they don't actually fit the criteria to be a true psychopath. The majority of people with ASPD wouldn't be psychopaths, whereas a lot of people with psychopathy would meet the criteria for ASPD, because having that lack of emotional capability can very easily lead to engaging in criminal and reckless behavior because they just don't care, right? So that's the major distinction I think I was making in the notes. But sociopaths, I mean, some people I think pretty much consider sociopathy and psychopathy the same thing. Yeah, so I don't know as much about the distinction there. I think it really depends on whose definition you're going by. But definitely ASPD and psychopathy are not the same thing. And the thing that bothers me is this DSM only lists antisocial personality disorder. It doesn't have criteria for psychopathy in it anymore because they replaced it, but they're not actually the same thing. So that was what my big beef was, that I wrote like a giant 30-some page paper on last semester, because they took out psychopathy from the DSM. And I was mad about it, apparently. I just find that stuff fascinating. But yeah, not something you super need to focus on for the exam, just something that I personally find really interesting. Oh, oops. Just trying to minimize instead of sharing screen. Let's go back to this and see. I think we just got a couple things left. Okay, so yeah, the last part is basically the drug therapies. So just knowing the basics, like the 3 types of antidepressants, so the tricyclic, the MAOIs, and the SSRIs. You don't need to know exactly how each of them functions and stuff. It's more just kind of knowing that there are like kind of 3 types and that there are some differences. Mood stabilizers, primarily we talk about lithium. Lithium carbonate is used to treat bipolar disorder a lot of the times, but the problem with lithium is too much is lethal and not enough is useless. So there's a very small therapeutic window of like how much is enough to help treat bipolar. So you really have to like be keeping a really close eye on treatment of someone who's being treated with lithium. There are newer drugs that are used for mood stabilizers. Some antipsychotics actually have been shown effective for treating bipolar as well. But yeah, so mood stabilizers will be more for the treatment of like bipolar disorder more than anything, because antidepressants, of course, are for depression. Antidepressants are actually also the drug therapy of choice for most anxiety disorders. A lot of people think an antidepressant is just for depression, but antidepressants, if you're treating either anxiety or depression long-term, you're typically going to use an antidepressant. When we talk about anti-anxiety drugs, those are usually ones that would be used for something like a panic attack, where you're trying to like calm down the body's physiological arousal. So you don't tend to take anti-anxiety medication super long-term, things like benzodiazepines. They can relax you and calm you down. They slow your nervous system down. But the issue with them is that they have high potential for addiction. and things like that. So you don't typically like take like a benzo every single day, whereas an antidepressant, you would take it every single day in order for it to function. And over time, antidepressants will typically relieve symptoms of both anxiety and depression. Sometimes the two might be prescribed together, especially because with antidepressants, there's usually at least a 4 to 6 week window before they really start to take effect. So in that case, you might be prescribed an anti-anxiety medication for the meantime, for if you have like flare-ups of anxiety before they really kick in. But typically anti-anxiety isn't like a long-term solution. Antipsychotic drugs, kind of exactly what they sound like. They're used in the treatment of psychosis, so things like schizophrenia. The first generation of them had some really negative side effects. So there was a condition called tardive dyskinesia, which is like a muscular condition, and it was like really severe tremors and stuff. And a lot of people if they were taking those first generation antipsychotics would develop those types of side effects. So we do have newer second generation ones now that are much more much less of a risk of those intense side effects. And then finally, we have some of the biomedical, like more invasive, like surgeries and things like that. So you're not going to really focus on those. Again, it's more, this stuff is more of like multiple choice at this point. There's just different techniques. So focal lesions would be systematically destroying a small area of the brain to try to deal with symptoms. You only use these things if like everything else has failed. Electroconvulsive therapy, you're literally shocking the person with high voltage of electricity, and it can be really effective in the treatment of very severe cases of depression and OCD when nothing else works. But it does come with some side effects such as the memory loss and things like that. We've come a long way with those techniques, but they're still not perfect by any means. And then the RTMS and the DBS, so direct brain stimulation, and the transcranial magnetic stimulation, excuse me. Those are basically using either magnets or like kind of electrodes like in the brain, like to stimulate certain brain areas or inhibit certain brain areas. So if you have an overactive amygdala, for example, which is, we know the amygdala is really heavily concerned with like fear and aggression responses and stuff like that, then you might be able to kind of slow down that area, things like that. So those are non-invasive, or at least the RTMS is non-invasive. It's just like a magnetic coil like outside of your head, but they can be really effective in treating some disorders that can't really be touched by other biomedical treatments or therapeutic treatments. So the main time you're going to be using stuff like this, these last few, is if you've tried all the other treatments and they really just haven't worked. I will okay, let me just pop up the notes quickly just to make sure I didn't miss anything important there. And then I think we should be good. Okay. Yeah, okay. So that's the 3 types of antidepressants. SSRIs are pretty much the most common at this point. These 2 aren't used as much anymore. They had higher rates of side effects than the SSRIs. We also sometimes use SNRIs, so selective norepinephrine reuptake inhibitors. They all have the same kind of function. They're increasing the serotonin, norepinephrine, and things like that within the brain. Yeah, so mood stabilizer, you got lithium carbonate. But yeah, we do sometimes now use anticonvulsant or antipsychotic medications to help treat bipolar, because again, they have less severe side effects in that really small therapeutic window that lithium has. Anti-anxiety. So yeah, we do know that those benzodiazepine drugs, they can have serious side effects and come with a risk for addiction. So we do try to kind of prescribe them less often and use them for shorter periods of time. So they're not something you're taking like every single day typically. And then the antipsychotic, like I said, the first generation, they had a tardive dyskinesia, so involuntary muscle movements and facial tics was kind of a severe side effect sometimes of those. So the newer ones, the atypical antipsychotics, are less likely to produce the same kind of side effects. They still do carry some risk. This one I thought was really interesting. The MDMA for PTSD, that's a newer thing, but apparently it has been shown to be promising. Yeah, we do not do frontal lobotomies anymore. That should be pretty obvious at this point. Focal lesions, though, are like kind of a very much milder form of a lobotomy. You are going in and destroying very small areas, very specifically, not just kind of ice pick lobotomy through the eye socket. ECT, again, it's not electroconvulsive therapy. repetitive transcranial magnetic stimulation. So you're using kind of magnetic coils. And then deep brain, so you are going to be inserting the wire for this one to stimulate certain areas of the brain, but it's not as risky as some of the other procedures would be, but it does still have risk of like internal bleeding and stuff like that. And I think that is everything. Sorry, I know I kind of rushed through that second half. Does anyone have any questions on any of the chapter 16 stuff before I let you go? Someone just left, so I'll take that as a no.